This is Stephanie Huff, and I am recording the Oxygenation lecture for COPD. So this is exemplar 15.3 in your book. An overview of COPD. This is an obstructive pulmonary disease. This is a group of disorders that are those that cause obstruction of airways, usually by a combination of bronchoconstriction and inflammation. COPD is a specific progressive disorder. It includes asthma, bronchitis, which is acute or chronic, and emphysema. It irreversibly affects lung function. It is not curable, but can be managed or prevented by medical interventions and lifestyle choices. Typically, it includes components of bronchitis and emphysema. It can include one or the other or both. Usually, though, one is more dominant over the other one. It also slowly alters the structure of the respiratory system over time. It does cause irreversible effects of lung function. It does have periods of exacerbations. Often this is related to respiratory infections, which will increase their symptoms of dyspnea and sputum production. The sputum production can be mucus or mucopurulent matter that is expectorated from the lungs through coughing. In COPD, the lungs don't recover after an exacerbation but have progressive destructive changes. Just a little patho and etiology. COPD, this has repeated exposure to respiratory irritants that damage the structures within the lungs. This damage occurs to the small and large airways, causing increased mucus production, which causes an arrest of the cilia action, which is what basically causes that irritation that makes you cough effectively and cough things up. They have excessive amounts of mucus. This causes edema, which also causes the airways to narrow. And this equals airflow limitations, which further causes air trapping and hyperinflation of the lungs. And that's why you end up with that barrel chest. Chronic bronchitis is a disorder of excessive bronchial mucus secretions. Emphysema is characterized by destruction of the walls of the alveoli. This results in enlargement of abnormal air spaces. People with moderate to severe asthma, persistent for most of their lives, may develop COPD due to airway remodeling and damage to the alveoli over time. And so that's why asthma is often a comorbidity with COPD. This is a leading cause of death, illness, and disability. Talking about COPD, and again, not curable. It can be preventable. In 80% of the cases are smokers that develop COPD, so if we can get them to stop smoking, that will decrease their chances of developing COPD. Environmental exposures are often play a role in the development of COPD. This could be through occupational and environmental causes, and this could be indoors and outdoors, just depending on the type of work that the individual does and the exposures that they come in contact with. All right, and so this is just a picture of examples of what healthy alveoli look like versus COPD. It also shows you the difference between chronic bronchitis, looking at the airways, and a normal airway, and you can see how they're much more narrowed. And again, with emphysema, it's showing you the normal alveoli versus alveoli for emphysema. All right, risk factors. The smoking is the greatest risk factor for the development of COPD. The more they smoke, the greater their risk for development of COPD. Short-term exposure to high levels of irritating substances is also a risk factor, as well as long-term exposure to chemical irritants at work or through their hobby. Prevention is the key, not engaging in behaviors linked with the etiology of the disease. So basically, if they're a smoker, they need to stop smoking. All right, and then this is a picture of a cigarette and showing lots of the chemicals that go into the making of a cigarette. The tar does contain approximately 4,000 chemicals. There's over 60 carcinogens that have been isolated from cigarette smoke, including cyanide, formaldehyde, and ammonia. The effects of nicotine will increase the heart rate. It also causes peripheral vasoconstriction, so they don't have as good blood flow to their extremities. It also increases their blood pressure and their cardiac workload. The effects on the respiratory tract causes an increase in mucus production. They will also have hyperplasia of the mucous membranes. The hyperplasia will reduce the airway diameter and increases the difficulty of clearing these secretions. So basically they just can't cough it out. They have lost or decreased ciliary activity. They also have destruction of the alveolar walls. Carbon monoxide is also a component of tobacco smoke, and it binds more readily with hemoglobin than oxygen does. And so basically the carbon monoxide takes up all the receptors so the oxygen can't connect to the hemoglobin. And this reduces the smoker's oxygen carrying capacity as well. So they have less oxygen going to their heart, causing the heart to pump faster to adequately supply the tissues with oxygen. And so you can see there's a lot of other things that go into the making of cigarettes. So all of y'all that smoke, this is kind of what you are inhaling in your bodies. All right, so manifestations, presentation will vary from simple bronchitis without disability to chronic respiratory failure and severe disability. Manifestations typically are absent or mild early on. With bronchitis, a lot of times an intermittent cough is the earliest symptom, and it usually occurs in the morning with expiration of small amounts of sticky mucus. Basically, they attribute this to just a smoker's cough and don't really think anything about it. They will seek medical help when they have acute respiratory infections, with dyspnea being their main concern. And dyspnea is often very progressive, and it usually only occurs with exertion. Patients rationalize this that I'm just getting older, will gradually get worse until they have dyspnea at rest as well. That thin, small amounts of sticky mucus will also progress to copious amounts of thick, tenacious sputum. With emphysema, dyspnea is usually their first symptom. Cough is usually minimal or absent. They will seek a tripod position to help with their breathing. All right, so more about COPD. It does encompass two types of obstructive airways disease. The main ones are chronic bronchitis. Cigarette smoking is going to be your major factor, and this is the presence of chronic productive cough for 3 or more months for 2 years, and they have ruled out other causes. And they have recurrent infections are very common due to impaired ciliary action, so they can't clear out the airways. A lot of times people that smoke, whenever they get sick, it usually goes straight to their lungs pretty quickly. and that is the reason for that. Emphysema, again, strong causative factor is going to be cigarette smoking. With emphysema, they will have abnormal permanent enlargement of air spaces distal to terminal bronchioles. This is accompanied by destruction of their walls without obvious fibrosis. The alveolar wall destruction will cause the alveoli and air spaces to enlarge, and this will affect their gas exchange. That's where your gas exchange takes place. A little bit more about chronic bronchitis and emphysema. Chronic bronchitis, they are also known as the blue bloaters. Usually their color is a dusky to a cyanotic color, and that's where you get the blue from. They end up with cardiac enlargement. Lung sounds, they may have bronchi and possibly wheezing. They use their accessory muscles to breathe. Chronic bronchitis leads to right-sided heart failure. So you will see JVD, so that's jugular vein distension. They will have edema, enlargement of the heart and the liver. They will have digital clubbing on their fingers, and that's just from the chronic hypoxia. They will have an increased CO2 retention because of the increased obstruction and decreased residual lung volume will increase, and this gives them the bloater. And that's when you have the barrel chest. Your emphysema, they are known as pink puffers. They have a decrease in CO2 retention, and so they end up being more pink colored, and that's where the pink comes from. So they have less hypoxia than chronic bronchitis. They used pursed lip breathing, and this is a type of hyperventilation, and that's what gives them that the puffer. And this is done to prolong expiratory time. They will also have barrel chest. Lung sounds are usually diminished. They also have accessory muscle use. They have a thin appearance, and they are tachypneic, and that's just breathing fast. All right, so some of your physical examination findings. They will have, with emphysema, they will have that prolonged expiratory phase. They hear wheezing in their lungs, decreased breath sounds. They will have an increased anterior-posterior diameter, that's known as the barrel chest, and that's from that chronic air trapping. They may need to be in a tripod position to breathe. They may use pursed lip breathing as well to aid in respirations. And so pursed breathing, this is when they exhale through narrowed opening of the lips, and that's their lips are pursed like they're kissing. The pursed lip breathing will also promote more alveolar emptying while maintaining the open alveoli. It prolongs exhalation and prevents bronchial collapse and air trapping. All right, so this is an example of the barrel chest and also the pursed lip breathing. And so you can see when they inhale for 2 counts and exhale for 4 counts. So they have that prolonged expiratory phase. So they're breathing in through their nose and then out through those pursed lips. All right, the prolonged impairment of gas exchange from COPD eventually leads to cardiac dysfunction. They will have developed chest pain and hypertension. This will lead to heart failure. So they'll end up with symptoms of heart failure. So you may hear some like crackles in their lungs where they're holding on to that fluid, some peripheral edema. Caloric demands do increase as effort to breathe increases. Tachypnea means that eating is going to be harder, so they often, in late stages, this makes eating even harder, so they're not consuming as much because it takes so much energy and to eat that they get so short of breath that they end up not eating as much. But during the later stages, they have increased caloric demands with decreased calorie intake, so weight loss and possible anemia may result. They will also have anxiety, and that's related to the dyspnea that they have. There's a really good table in your book on page 1010, and it does compare the COPD. It compares the bronchitis, emphysema, cardiac dysfunction all in one table. It gives you all the manifestations and clinical therapies for each one of those. So it may be helpful for you to look at that table, and you can see all of this at one time. All right, collaboration. Be aware of who is caring for the client that has COPD living at home. You want to make sure that you include them in this collaboration. You want to discuss the need for sufficient caregiver information and training to provide care that meets the best practice guidelines. Collaboration, a lot of times you will have physical therapists, nutritionists, a pharmacist, family members, and counselors to help patients achieve their outcomes and improve their quality of life. So we're talking about a lot of the healthcare team will be involved in this. Looking at diagnostic tests, your pulmonary function testing in COPD, they're looking at the total lung capacity and the residual volume. Usually that residual volume will increase. Looking at VQ scanning, that is done to look at the amount of dead space and areas that are inadequately ventilated. The dead space is basically where they have so much constriction of the airways that that dead space is areas of the lung that are not participating in gas exchange, and no air is getting to that area of the lungs. The serum amitriptyline levels, that is used for families that have a history of COPD, and they're screening for the deficiency in those levels. Your ABGs will evaluate their gas exchange, pulse oximeter, again just looking at what their O2 saturation is. There's an exhaled carbon dioxide, which is also called a capnogram, and that evaluates alveolar ventilation. Your CBC with differential will show an increase in their red blood cells, and that's the body trying to pump out more red blood cells, trying to help with this hypoxia. They will also have an increase in their hematocrit. This is known as erythrocytosis, and as chronic hypoxia stimulates increased erythropoiesis to improve oxygen carrying capacity of the blood. So basically they're just trying to get out more of these blood cells so that they can hopefully get more oxygen circulating throughout the body. Increased in bands and their white blood cell counts could indicate a bacterial infection. The increase in bands lets you know that this is a bacterial infection because those are immature white blood cells. When you're looking at your CBC and you're looking at your white blood cells, you have an increase in those, and you can have an increase with viral infections as well, but you're looking at the bands. Usually for bacterial infection, your bands are low and your segs are high. I'm sorry, your segs are low and your bands are high. And basically your segs are your mature white blood cells, and there's so much infection that the body's pumping out more and more white blood cells faster, and so they're not able to mature them before they send them out because they're trying to fight off this infection. And you've used up all your mature ones, which are your segs, and that's why the segs are low and your bands are high. When you're looking at a chest x-ray, it may show white patches indicating hyperinflation of the alveolar sacs filled with secretions. You'll see that in emphysema. For chronic bronchitis x-rays, you'll see long fields of white, and that is usually from the increased secretions that they have. All right, surgery, lung transplants, you can do single or bilateral. Both of these, they will have successful 2-year survival rate at about 73%. Lung reduction is experimental for advanced diffuse emphysema and lung hyperinflation, and it's a procedure that reduces the overall volume of the lungs. It reshapes them and improves elastic recoil, and this results in improved pulmonary function and exercise tolerance. It also helps to reduce their edema, and this is only done when medical therapy no longer is effective. All right, looking at some of the pharmacologic therapy, immunizations, they will have them get a flu shot and a pneumonia shot, and so these are their vaccines that they'll need to get. They usually put them on broad-spectrum antibiotics if an infection is suspected, and that's usually related to purulent sputum and dyspnea. And this, if they can get a sputum culture, what they'll do is put them on broad spectrum, and then once the sensitivity comes back, they can narrow down that antibiotic if they need to. Bronchodilators are used to improve airflow and reduce air trapping, which results in improved dyspnea and exercise tolerance. Your corticosteroid therapy is used when asthma is a component of COPD. Steroids will improve symptoms and exercise tolerance and may reduce the severity of their exacerbations and need for hospitalization. It can be given orally or by an inhaler. Your bronchodilators can be given by a meter dose inhaler. A lot of times they'll use that with a spacer to make sure they can get all their medication. And it gives it a more effective use. You also have your dry powder inhalers, your DPIs. It can also be given by a nebulizer or even orally. Orally may promote adherence but has a higher rate of adverse effects. And I've already done the Camtasia of the pharmacology, and so there's a lot more detailed information on that lecture as well. Research indicating that statins may be useful, and this is associated with decreases in all causes of mortality related to COPD. It also helps with a reduction in rate of respiratory-related emergency care, and also targets airway inflammation. And like I said, that's research is going on about that. All right, looking at oxygen therapy, helps improve exercise tolerance and mental functioning. It also helps to increase their quality of life. Oxygen therapy reduces the rate of hospitalization and increases the length of survival. Oxygen may be used intermittently at night or continuously. Patients that usually have severe hypoxemia benefit the best with continuous use of oxygen therapy. Oxygen therapy can be used at home. It is used with caution in clients that have chronic elevation of CO2, which is what you'll see in your COPD patients. And the reason why you want to use caution is because oxygen that's given to them can increase their PaCO2 levels, and this will lead to an increase in solvents and respiratory failure. So you need close monitoring of their level of consciousness and ABGs during oxygen therapy. Sometimes in an acute exacerbation of a COPD patient, you need to put them on high-flow oxygen, so a lot of times a non-rebreather will be used. But you have to watch and make sure that you don't keep that on too long and switch them back over to a nasal cannula at a lower percentage of oxygen just as soon as you can. because basically what you're doing is blowing out that oxygen drive for them to breathe, and that oxygen drive is an increase in their CO2 level. Long-term oxygen therapy a lot of times is used for that severe and progressive hypoxia. HOMO2 can be supplied as liquid oxygen, compressed gases that are located in cylinders, or you can have oxygen concentrators that are used at home. Acute exacerbations, like I said again, may necessitate that increased oxygen. Sometimes they may put them on expiratory positive pressure assistance with face mask, and that would be like your CPAPs or BiPAPs, or sometimes they have to be intubated and put on mechanical ventilation. Like I said, they try to keep those oxygen levels as low as they can so that they don't blow out that oxygen drive for these patients. All right, and so again, we talked about in class a little bit about oxygen therapy and smoking, and about how it is combustible. And so here's an example of a guy that appears he had a nasal cannula on while he was smoking his cigarette and suffered the consequences. All right, so percussion, vibration, and postural drainage. Does help. This is a dependent nursing function that's performed according to the primary care provider's orders. The order should be position first, percussion, then vibration, and then a lot of times that will help them to cough. So a lot of times they can cough it up. They can also deep suction these airways if they need to. Usually they do 10 to 15 minutes per position. This will help in removal of those secretions by coughing and suctioning. You want to auscultate the lungs to compare to baseline. You want to document the amount, color, and character of the expirated secretions. You want to assess their vital signs, especially heart rate and respiratory rate, and note the signs of intolerance, which would be pallor, diaphoresis, dyspnea, nausea, and fatigue. So the basically the percussion is also sometimes called clapping, and it's a forceful striking of the skin with a cupped hand, and it causes a hollow popping sound. It actually sounds a lot worse than it actually is, but you want to percuss over the congested areas of the lungs, and this can mechanically dislodge those tenacious secretions from bronchial walls. It's not usually done over the breast, sternum, or spinal column, or the kidneys. Vibration is a series of vigorous quivering, and it's produced by the hands placed flat on the patient's chest wall, and it's used after percussion to further help loosen secretions. A lot of times they'll do these with meals 2 to 3 times a day. They give a bronchodilator before this to just kind of help open up those airways a little bit. Your postural drainage is what they're using for the positioning, and that uses gravity to help drain those secretions from different parts of the lung segments. The secretions that are left do promote bacterial growth, which would lead to infections. And it can also obstruct smaller airways. And so there are a wide variety of positions that are used, and I did put some YouTube videos out there that just kind of show you some of the percussion, vibration, and positioning for that postural drainage. And here again is some of your positionings, and you can see how they have the head down, just kind of helping, and then showing you the cupped hands for the percussion. And then these are pictures of, at the bottom, they have vests that will actually do the percussion for you. And so you wear these vests, and it actually vibrates and does the percussion as well. And you can see both of the individuals are using a bronchodilator to also help. but they have different colors and they've got different machines to make them, try to make it a little bit more fun for people. All right. Other interventions: smoking cessation can prevent COPD and help improve lung function. They can also use air filtration systems in the home that will kind of help with these allergens and airway irritants that may be found in the home. That way they can help avoid those exposures. They need to remain indoors during periods of significant air pollution to prevent an exacerbation. So that may be like even with pollen, when the pollen's really heavy, or if they live in an area that has increased pollution at certain times, maybe a factory is located nearby. Pulmonary hygiene measures can also be used, and that is to increase hydration, make sure that they have effective coughing, percussion and postural drainage may be used. Cough suppressants are usually ineffective. You want to avoid sedatives because that can cause retention of secretions. Exercise, like doing something regularly, like walking for 20 minutes at least 3 times a week. They can also do swimming, golfing, different exercises, but this will help improve their exercise tolerance. It enhances their ability to do their activities of daily living. It helps prevent deterioration of their physical condition. Hydrations, a lot of times they will use humidifiers in their room, and that helps to keep the secretions thin. Some of your complementary and alternative therapy diet measures: they want to minimize the intake of salt and dairy products. This will help to decrease mucus production and keeps it more liquefied. The diet needs to replace protein and calcium, and this is usually found in dairy products, so they need to make sure that they're getting other foods that are high in calcium and protein besides the dairy products. This will help to maintain nutritional balance. Hot herbal tea with peppermint acts as an expectorant to help relieve chest congestion. Acupuncture and hypnotherapy, as well as guided imagery, can help them to quit smoking, but evidence of the effectiveness is questionable. Some people will swear by it, other people say it doesn't help. All right, nursing process. Nursing care is going to be focused on promoting oxygenation. So in your promoting health, that is going to include smoking cessation and helping to reduce risk of infections and maintaining client safety. You want to teach the client how to maximize self-care, and so that may be even doing a few things at a time and taking rest between activities. You want to teach them to know when to notify the healthcare team. So you'll have to go over specific symptoms with them so that they can get treatment for these infections. And if they start to get worse on medications, they may need to contact their physician. They may need changes in dosages or even changes in their medications. All right, so looking at assessment, you want to get a good health history. You're looking at current symptoms. You're looking at cough, shortness of breath or dyspnea, the amount of sputum production they have, their activity intolerance. Looking at the frequency of respiratory infections, and when was their most recent episode. They have a previous diagnosis of chronic bronchitis, emphysema, or asthma. You're also looking at their smoking history. You're looking at pack per years. This is basically the number of packs they smoke a day times the number of years they smoke. So an example would be if they smoke 2 packs of cigarettes a day and they smoked for 7 years, you would say 7 times 2, and that will give you 14. So they are 14 pack year history. So a lot of times that's important to know what their pack year history is. And I have seen that on test before. You also want to know what current medications that they're on. Do they have a history of secondhand smoke or other pollutants that they've been exposed to? Looking at their physical examination, you want to look at their overall general appearance. Looking at their weight according to their height. So that kind of looks at their BSA and BMI. Looking at their mental status. You want to obtain vital signs, including their temperature, skin color, their overall temperature, whether that be an oral temperature. You want to look at the AP lateral chest diameter, any use of accessory muscle use or nasal flaring. Look for pursed lip breathing, tripod position, breath sounds. You want to evaluate their breath sounds throughout their all their lung fields, because sometimes they may seem clear up top, but they may have some other issues down in the lower bases where you hear bronchi. You want to look at their neck veins to see if they've got any jugular vein distension. You want to monitor their apical pulse and their heart sounds, also assessing peripheral pulses as well as edema. All right, so your diagnosis, here are some of your NANDA diagnoses. Ineffective breathing pattern, ineffective airway clearance. This is a high priority due to obstruction of the, due to the obstructive nature of the disease. So usually the airway clearance is the highest priority. Activity intolerance is another one. Imbalanced nutrition, usually less than body requirements, especially with your emphysema. They have some compromised family coping, decisional conflict, and that's usually related to smokers. Looking at the planning, the client will be able to adapt breathing patterns to meet oxygen demands adequately. They would experience ease of respirations with use of positioning and pursed lip breathing. They will maintain a patent airway allowing adequate oxygenation. Maintain oxygen saturation levels above 90%. They will tolerate activities allowing for completion of their activities of daily living. So looking at implementation, promoting airway clearance, remember this is the highest priority. You want to assess respiratory status every 1 to 2 hours, monitor their ABG results. You want to obtain daily weights, INO, looking at hydration assessment. You're looking to see if they have any dehydration, looking for thick secretions. You also want to look for fluid overload, because this does compromise their respiratory status. So thick secretions may be found with dehydration, and then fluid overload will be found with overhydration. You want to encourage fluid intake unless it's contraindicated. This helps thin those secretions. You want to place them in a Fowler's, high Fowler's, or orthopnic position. This helps improve ventilation and worker breathing. The orthopnic position is basically where they have a bedside table and they are leaning their upper arms over that table, and it's basically another way of helping open up those the lungs. Assisting with coughing and deep breathing every 2 hours. They usually do this every 2 hours while awake. Promoting airway clearance continued. You want to provide tissue for them to cough their secretions in. Also a paper bag for disposal so that they're not just leaving them laying all over their bedside table and then you have to come in there and try to clean it off. So if you'll give them something to put it in, that way you only have to change out the bag. This will also help to decrease the spread of respiratory organisms. You want to refer them to a respiratory therapist. for percussion, vibration, and postural drainage. Administer the expectorants, bronchodilators as ordered. Provide them with supplemental oxygen as ordered. Looking at enhancing their breathing patterns. You want to monitor vital signs and lab results. You're looking for tachypnea, tachycardia, hypertension, increased hypoxemia, and hypercapnia. Looking for signs of compromised respiratory status. You want to assist with ADLs as needed. Allow them to do what they can for themselves to help promote independence, but sometimes you may have to help them a little bit more at first with the ADLs because they're so short of breath. Do you want to provide rest periods between activities? You want to teach and assist them with breathing patterns. This may be pursed lip breathing, abdominal breathing, relaxation techniques, and then again your medications as ordered. Promoting activity, you want to assess how well the client is meeting their ADLs. You also want to discuss the importance of spacing their activities and rest. You want to design an exercise plan to meet their current level to help build stamina and strength, and this will include the interdisciplinary team of physicians, physical therapists, and your client. Promoting balanced nutrition. You want to assess their nutritional status. You want to observe and document their food intake, looking at the types of food they're eating, the calories, and the amount. Monitor their lab values, especially their albumin level, and that's for protein, and their electrolytes. Consult with a dietitian for helping with meal planning and nutritional substance. Provide frequent small feedings and snacks. This will help decrease their fatigue. Instead of having 3 big meals a day, they need to have 6 or 7 smaller meals. Make sure that the client is seated or in a high Fowler's position for meals. This helps promote lung expansion and helps to decrease their dyspnea. You also want to assist them to choose preferred foods. So a lot of times they may have them bring foods from home, something that they really like, to help get those calories in. Make sure that they have snacks at the bedside to provide added calories as part of their intake. Make sure that they do mouth care before meals. This will enhance their appetite. They may need to consult with a physician if the intake is poor. Sometimes they may need enteral or even parental feedings. Sometimes that may just be a short-term thing. Sometimes it may be a long-term thing. Promoting family coping. You want to assess the interactions between the client and their family. Are these good interactions? Are they bad interactions? They usually have a higher success rate if their interactions are well and good and not bad. You want to assess the effect of illness on the family, looking at the different roles and the relationships. So if this is somebody that's usually the head of the household, the main person that is making the money for the household, it may affect the family a lot more than if they were not the primary breadwinner. You want to help the client and the family identify strengths for coping, help provide information and teaching about COPD, and make sure that they understand, because a lot of times we'll give them information and then they act like they understand, but they really don't have a clue what we're talking about. So a lot of times you can do that return teaching to make sure that they're understanding. You want to encourage their expressions of their feelings and helping family recognize any hindering behaviors that they may be adding to this. You want to encourage the family to participate in the care, but you also don't want them doing everything for the patient where they don't have to do anything for themselves, because you do want to promote independence and get them to do as much as they can on their own, and that's going to help them in the long run. You want to initiate conference that involves the client and the families. This is a place that you can facilitate communication and help to problem solve. different issues that they may have. You want to advocate for the client if family dysfunction interferes. You can also refer them to support groups if they're available in the area. Social service consultation is really good because they can help with resources and stuff when they go home. Refer them to different types of community agencies. This could include home health, Meals on Wheels, where they deliver meals straight to their house, even homemaker services that can help with like house cleaning. Encourage smoking cessation. You want to assess the client's knowledge, understanding, and the different choices they have. The decision does begin with the client. If they are not ready and willing to actively participate in smoking cessation, then they're not going to be successful. You want to acknowledge concerns and values and beliefs. Listen without making any judgments, because still it is their it has to be their decision, and basically you just need to support whatever decision that they come up with, even if you don't agree with it, but you must support them and not make judgments openly. Spend time with the client and encourage their expression of feelings. You want to help plan the course of action with the client. Whatever their decision is, you just need to help plan that course with them and demonstrate the respect for their decisions, whatever they may. Provide referrals as needed. And that's usually related to their decision that they've made. Evaluation, this is going to be the client consistently maintains their oxygen saturation greater than 90%. Client demonstrates the appropriate modifications of their activities of daily living to help decrease fatigue. Client should be able to maintain a patent airway using medications such as their inhalers. The family is able to describe resources that are available to them. All right, so these next couple of slides, we're going to do a couple of questions. Patient with COPD has a nursing diagnosis of infected breathing pattern, which is an appropriate action to delegate to the experienced LPN or LVN under your supervision. And again, LPN is licensed practical nurse, LVN is licensed vocational nurse, and they mean the exact same thing. So A is observing how well the patient performs pursed-lip breathing. B is planning a nursing care regimen that gradually increases activity and tolerance. C is assisting the patient with basic activities of daily living. D is consulting with the physical therapy department about reconditioning exercises. So this is going to be what is appropriate action to delegate to your experienced LPN under your supervision. All right, so it should be A, observing how well the patient performs pursed-lip breathing. Your planning of care and consulting with the physical therapy are RN roles. Assisting patients with activities of daily living can be delegated to the unlicensed assisted personnel. All right, so the patient with COPD tells the UAP that he did not get his annual flu shot this year and has not had the pneumonia vaccine. How would you instruct the UAP to report the vital, you would be sure to instruct the UAP to report which vital sign? A, blood pressure 152/84, B, respirations of 27 breaths per minute, C, a heart rate of 92 beats per minute, or D, an oral temperature of 101.2. All right, so D, a temperature of 101.2 is the one that you reported because they did not get their annual flu shot and have not had their pneumonia vaccine. So they are at risk for developing flu and pneumonia, which are both signs of infection. And so that oral temp that's elevated will be a sign of, could be a sign of infection. All right, so you're evaluating and assessing a patient with a diagnosis of chronic emphysema. The patient is receiving oxygen at a flow rate of 5 liters per minute by nasal cannula. Which finding concerns you immediately? A, find bibasilar crackles, which is just crackles on both sides of the base. B, respiratory rate of 8 breaths per minute. C, patient sitting up and leaning over the nightstand. D, a large barrel chest. Okay, and your answer should be B, respiratory rate of 8 breaths per minute, and that is showing you that they are getting tired, so they're not breathing as fast, and so that is a low rate. Large barrel chest, you would expect with chronic emphysema. Fine bibasilar crackles, you would also expect because of the overinflation of the alveoli. A lot of times they will have some fluid in there. And then the C, the patient sitting up and leaning over a nightstand, that is that orthopnea position, and so that is acceptable. All right, and that concludes the COPD. And again, as always, if you have questions about this, please let me know, and I will try to help clarify anything for you.